Thank you. I'm most honored to speak at your conference today at the beautiful city of Matsumoto. I thank Mayor Dr. Sugenoya for your invitation. Thank you. And you have asked me to tell you about healthcare innovation in the Netherlands. I work for the Ministry of Health, Welfare and Sports. I'm a project manager there on the policy field of innovation and e-health. I'm grateful here to be able to share our experiences, and I hope to inspire you, healthcare providers, research, industry, government, because when it comes to bringing better care, we need to work together and continue to ask ourselves, why are we doing this? The answer is simple for us in the Netherlands. We always start with the needs of the patient or the civilian, because they're not always patients. They can be pregnant women or healthy people trying to work on their health. And when you take the patient or a person as a starting point, you will make the right choices to make care truly patient-centered. When I came to Japan, I prepared and I tried to understand what was special about Japan. And in the Netherlands, in the top 10, we have a book. It's called Ikigai. You will probably know the word. And what struck me is the part about a sense of community. And your team also today is bridging health to community, to people. So I think I chose the right book. I work for the ministry, as I said, and the ties between the Netherlands and Japan go back a long time. And our Prime Minister, Mark Rutte, has also met your President, Prime Minister Abe-san, in 2015, and our former Minister and former State Secretary came to Japan in 2015 and 2016 to exchange on subjects of sports and e-health. And these are very valuable meetings for us to get each other, to know each other, and discover that we face the same challenges about an aging population and about giving better care for the elderly. Since a month now, we have a new administration, and we've got now two ministers and a state secretary who will gladly come to Japan in the future and exchange more on these subjects. First, something about the Netherlands. The Netherlands, we have 17 million people. Our expenditures on health are 70 billion, and it's approximately 10% of our GDP. Our life expectancy average is 80 years, and I looked up on WHO, and for Japan it was, with the same definition, 83 years. And roughly 1 million of the 70 million people are employed in healthcare. As life expectancy is growing, many diseases like heart vascular conditions can be cured now. The population is aging, and our percentage of people over 65 will increase in the next 20 years in the Netherlands from 18% to 25%. And we will get older and have multiple chronic diseases. And our elderly need support in their day-to-day lives. And healthcare is complex, meeting a lot of healthcare professionals in the integrated care circuit, and we need to organize that very good. Today I will talk about personal health records in the Netherlands, because for us it's a means to connect and inform the patient, but also professionals. We need to act now to keep our healthcare system sustainable, and we need to access high quality care and keep it affordable. Technology will prove to be crucial. This is not about high tech like a Da Vinci robot, which is used in a hospital. It's about low tech in the healthcare process, having a high impact on efficiency and on quality of life. But healthcare is very slow in implementation in the Netherlands and also in Europe. It's 20% of the change is technical. 80% is about people. It's about implementing new solutions in your healthcare process, and getting people to accept them and taking them with you in the process is the challenge for us. And we also learned in our meetings in Japan, in Tokyo Tuesday, that this soft side of the change in healthcare needs to be addressed. How do we change healthcare? So, the Dutch healthcare system is one of the best in the world. It's based on solidarity through medical insurance. It was third in this year's ranking of the Commonwealth Fund. Private health insurance companies and private healthcare providers play a key role in our system. It's based on managed competition. The Dutch the Healthcare Insurance Act is dating to 2006, and it's based on a number of universal principles. Health insurers are obliged to accept any resident based for basic insurance coverage, and they have obligation to contract sufficient care. There's a prohibition on differentiation on premiums and on based on background like age, gender, or condition. But first let me introduce Tim Kroesbergen. This video will say it all. It will show you how people, patients, work and live in their day-to-day lives, and they use e-health. Tim has a genetic disorder. It's known as brittle bones disease. Because of his disorder, he needs help starting the day and going to bed. But for the rest of the time, he's self-supporting, and he uses e-health in his life. So he can manage it very independently. Video conferencing, for instance, helps him communicate with his community nurses and his general practitioner. A digital platform, All of Me, helps him connect to people like him and healthcare professionals. A tool for self-measurement gives him insight and peace of mind. I will show you the video and I will explain and say what he's saying, because it's in Dutch but with English subtitles.
Een paar jaar geleden, toen was haast iedere herfst dat ik een longontsteking kreeg, of erger, waardoor ik in het ziekenhuis kwam. En sowieso fluctueerde bijvoorbeeld mijn energielevel heel erg.
So a few years back, he had lung problems and his health condition fluctuated very rapidly.
Wat mij veel inzicht geeft.
And these fluctuations made him insecure. And then he used e-health to give him peace of mind in how he was really doing.
Ik nodig heb met opstaan, dus kleding aantrekken, wassen, als ik naar bed ga, hetzelfde liedje omgekeerd. En verder kan ik heel veel zelf.
So for a number of things, starting the day and ending the day, he needs people to help him.
Wat verschillende vitale tekenen van mijn lichaam kan meten. Temperatuur, hartslag en bijvoorbeeld de aantal zuurstof in mijn bloed. Ik zet hem aan en maak draadloos verbinding met mijn iPhone. Ik zet hem tegen mijn slaap aan. Hij is aan het meten. Ik heb de meting gedaan en ik heb de resultaten. En waar ik heel blij mee ben, is als ik me wat minder voel, dat ik dan relatief super gemakkelijk ja, de stand van zaken in mijn lichaam
So when
kan
he's
opnemen.
feeling
Als ik me bijvoorbeeld
not good
ongerust maak om iets.
from a day to day,
En het is
he
gewoon
uses
goed,
these
dan
devices
geeft dat gewoon heel
to
veel,
make it
rust.
objective how he's feeling by measurements, and he can share these measurements with his healthcare professional and have a discussion, and not just
Ik
be
had
in
veel
a
twijfels
in a
rondom
room
mijn
with a
handicap en
doctor
wat
saying
aankomt.
I don't
En
feel
niet van
right
wat-
without the data.
Wat er normaal was voor iemand met mijn handicap. Sinds een paar jaar zit ik op een platform, All of Me, met een heleboel
So eHealth,
andere
this platform connects
mensen
him
met
to the
handicaps.
world,
En de
to people like
ervaringen
him.
die ik daar kan uitwisselen, die zorgen ervoor dat ik ook zo'n boost heb gekregen
and it gives
in
him
zelfvertrouwen.
extra confidence. It boosts his confidence.
Dat ik gewoon een soort beter mens voel. Waar ik
makes
wel
him feel a
tegenaan
better
loop, is
person.
dat veel doktoren er nog niet goed mee weten om te gaan, of er totaal geen gebruik van
And this is
maken,
one of the
of
key
willen
elements.
maken.
He
Het
says
is nieuw, het is
our
eng,
my doctors
zeggen ze, en het
find
gaat
it
op een andere
hard
manier toch
to
goed, dus
handle
het hoeft
this
helemaal niet.
newfound
overheid
independence
die
based on
nog
health
wel,
data.
beter kan
They don't know how to
stimuleren
deal
door
with
bijvoorbeeld
these
artsen meer te
self-measurements.
onderwijzen van wat het kan brengen
He says
patiënten
we
en
need
wat
to
het
educate
de artsen zelf
our
ook,
doctors
kan
and help them
ja, ik heb
use
een handicap
the tools
die
that I
veel
have
voorkomt.
in our healthcare
Dus dan moet
process.
je ver reizen naar een dokter die er verstand van heeft. En vervolgens
And for
die
his
dokter,
condition,
die
he
ziet-
needs
ziet ook
video
heel veel
contact,
mensen die
so he
allemaal
doesn't have
heel
to
ver
travel
moeten
all the
reizen.
time
Als nou
to
een gedeelte
hospital,
daarvan
which is
gewoon bijvoorbeeld met
an
beeld
all
bellen
expedition for him to do.
ook met die arts zou kunnen overleggen, dan zou het waarschijnlijk veel tijd schelen voor die arts, veel energie voor de patiënten en worden er allemaal beter van.
So this was Tim, and we're very proud that Tim is part of our policy at the Ministry of Health, Welfare and Sports. People like Tim are frequently involved in making policy. We have them at the weekly board members meeting. We have a chief experience officer there who advises us on what choices to make on the field of healthcare. So, just a few pointers. We say that e-health is just regular health. So it's not something that's on top of healthcare. It's something that is going to enrich and should be used in the primary process. It's about low tech on high impact, and we wanted to use to help people move from the waiting room to the living room, making lives more easy and more independent. And we want to shift a balance from medical care to prevention, preventing those costs of chronic diseases. And everybody could be a CEO of their own health in the Netherlands. So there's never been an era of technology that has such a fundamental impact on society and healthcare. Every day in the Netherlands, in Europe, many innovations enter the market, like wildflowers in a field. Every innovation potentially changing and improving efficiency, quality, and patient safety. And at the same time, professionals and patients will find it difficult to choose which innovations will help them. And there's uncertainty about quality and about evidence. And these are very great barriers for them. And it is essential to bring some order into this beautiful but some uncertain chaos. So in the Netherlands we say that we need to bring some structure and bring some fertile ground for these innovations so that they can really reach the greater public. If you start to grow flowers and you want to sell them to your whole population, you cannot just use a field of wildflowers. You have to think out how you can create mass implementation and upscaling. And this is what we're doing actually in the Netherlands, looking for those best practices that have proven themselves but are still struggling to get beyond the pilot phase. So when the government or another institute supports a pilot, then how do you get it to reach the whole market? So some examples from the Netherlands. For instance, in Netherlands we have lecture①, telemedicine. It's probably one of the first virtual hospitals in the Netherlands. It was founded by a dermatologist who says, well, 80% of the things I'm doing day-to-day life is routine. This could be done cheaper and more effectively. So he implemented a system where GPs could take pictures and the specialists would look at the pictures from remote. And it has two sides. The cost go down, and also there was an education curve increase with the GPs, because they were taking picture and they got education on what kind of skin diseases there were. For instance, one of the most used websites in the Netherlands is Thuisarts. It's home doctor translated, and this is about medical information, giving people information about their condition when they're uncertain and they want to go to a clinic or medical doctor, but they don't know if it's the right choice. So they look at the information, and it saved up to 12% of the regular consults for the practice. People that were able to stay at home because there was nothing, there was no problem with their health, or they could be referred to a hospital instead. So within this innovation in the Netherlands, we noticed as a ministry that everybody was working on innovation, but there was no focus of energy. So our minister formulated 3 goals to make the priorities for the Netherlands for the coming year. We said the patient must have direct access to his medical data, and he must be able to measure these data and their health functions. And because we also have elderly and vulnerable people in the Netherlands, we need assistive technology and 24/7 contact for these people. And we said by 2019 we want this achieved. So I have 2 more years to achieve this. And one of the things we did in the Netherlands, initiating the MedMai program, which I will talk about. And that is an answer to the first 2 targets. So, our strategy in the Netherlands was aimed at stimulating a flourishing ecosystem and stimulating this incredible innovative energy of solutions that were produced by SMEs in the Netherlands. We needed to kickstart their solutions and scale them up. And for that, we have an approach which is represented in this slide. We are trying to create a good climate for these innovations and a fertile ground. Because what you see is innovations, they need to land somewhere, and they're starting to notice that they cannot connect with the healthcare systems of healthcare professionals like hospitals. There is no agreement on which standards to implement and how to connect. There are a number of basic IT utilities missing. And so we said, we must implement these utilities. It's about standards, it's about registers, it's about legislation, authentication when you access your data, and when we arrange this in a fertile soil, then all those innovations can stimulate, can grow up and upscale, so people can really use all those tools that are available but still not widely used. So in the Netherlands, we had some lessons in the past. In 2011, our Senate rejected a national electronic health record system. There was legislation, was brought to the chamber, and what happened is that we found out that the Parliament and Senate did not trust that privacy was adequately addressed in the legislation. we learned that we failed to build trust, and we did not take all the stakeholders and all the people seriously into the process. Our lesson is that if you fail, it will be probably because you did not involve the right parties. You will be maybe you have spoken to one stakeholder, or maybe it's just one pilot. But if you really want to be successful, you have to take everybody with you. So it was a hard lesson. It was 6 years ago, and in these 6 years, we started building trust again. Because, as you might know, building trust, it takes years to build, 6 in our cases, seconds to break, and forever to repair. We're trying to repair it, and we'll find out if it's we have given enough comfort to people to be able to put new steps in ICT. So we found out we had to involve everybody. So success for us is a team effort. And we had a failure, but we had lots of successes. And sometimes you forget to balance them out and look back and say, where are we now and what have we done right? We have our Health Insurance Act, which provides quality care to everyone. We have a national service, a citizen service number, which can be used to connect all the systems, people to identify people and connect social care to health care. One of the key system changes in the past years is to invest more in integrated chronic care. So we have a GP, we have a physiotherapy, we have a dietitian, and we have all these health professionals, and in the past they were all doing their part of healthcare delivery, but not communicating enough. So we had integrated chronic care introduced in 2014, and this was a big change. The Netherlands is part of the EU, so EU legislation and EU infrastructure is very relevant for us. And we had 2 very important steps the last years. The EU General Directive on Data Protection will be enforced in 2018, which will adequately protect the citizens' rights to data. For instance, one of the articles is data portability, which states that if a person or an institute registers data from you, you have a right to have that, access that, and also take it along with you to another device of your choosing. This means a great deal for innovation, because any supplier, any developer can count on this and develop new solutions. And in the EU, we started in 2016 in implementation of eHealth. It's a digital service infrastructure which can be used to exchange medical data from GPs or medication between countries. So when you are a tourist in Spain, for instance, and your medication gets stolen, but you're dependent on it, you can use the system to get new medication in Spain. And in the old days, that would be a real problem. So, as I said, success is a team effort. Maybe you know him. This is Max Verstappen. He is our hope for the future in Formula 1 racing. And what he does is he races very good, but his successes can only be achieved by doing this together. And this is also my message for today. If you make policy from the ministry or from the municipality, you better do it together. Involve all the stakeholders, ask the patient, and also involve developers, because then you know you have to make the right choices. So in the Netherlands, how did we involve everybody? We installed a National Information Council. We put the whole system in the room. In the Information Council, patient representatives, insurers, municipalities, GPs, hospitals, they're all part of a discussion. What are the priorities on IT for the next years? This is very important because in the Netherlands we do not have the authority to put down, top-down IT infrastructure on our system because they're private healthcare providers. So it took a long time to build trust and get to the right priorities. Our priorities for the coming years is increasing medication safety. We had a study in the Netherlands and we found out that 19,000 hospital admissions a year are caused by errors in medication caused by not having the right information. So you need to make your systems connect, register the medication that was prescribed and delivered, and connect all the pharmacies, the GPs, and the hospitals. And if you do not do that, then you get a lot of hospital admissions, and these people, they can be permanently disabled or get very sick. So the costs of these are enormous, as you will see later on. And after you define your priorities for the coming year, which is about medication, let me just clarify 3 more goals to be complete. So it's medication, it's patient access, which is about the MedMy program. It's about unity of language, because when you exchange data and you do not agree on the language you're speaking, then when you send it across, it's going to be not understandable. So the doctor will not understand what the information is about. And the last one is the exchange between professionals. So we have got 4 goals. And what was really interesting about this is that in 2014, we had 3 goals from the minister, top down, and it took us 2 years to make them owned and be taken responsibility by the healthcare professionals. So they said, okay, you minister, you have formulated these goals, but we adopt them now, and we're going to work on that. So the process of discussing honestly about what the priorities are and what the difficulties would be in implementation and the concerns would be on privacy was a very important step in the process. As I said, it's not about technology, it's about the soft side and getting everybody on board. So after you define your priorities, you want it to grow, and you need to let it grow together. And the MedMy program was initiated to facilitate that. So this is the logo of the MedMy program, and our tagline is personal health data in the palm of your hand, representing our ambition to give people access to all their health data in the Netherlands. So, an important step towards patient empowerment is to provide the patient with access to their health data. And you give them transparent insight on their medical history, which will allow patients to make better decisions about their health and their health management. For that reason, it's important to provide patients with access to their electronic health records, and they being able to collect these data and manage them and share them with their doctors, for instance, or also the family. The next step is to include data that is generated by the patient itself and use that data in the healthcare process for extra information. A growing number of people is interested in using their personal health data. This is a development that is active in Netherlands, but also in the whole of Europe. And every day, more and more apps and websites enable people to manage their information about their health. But there's something still missing. These positive developments are very good, but the problem is they cannot access the data, and their data is spread all over the healthcare field. So that would be the question, how many places? So one of our patient advocates in the Netherlands, Frida van der Sar, she has MS. She says on Twitter, I've been thinking about where my medical data is stored actually. I'm visiting 3 hospitals within their 8 departments. I've got 2 GPs, I got 4 physiotherapists, and I got rehabilitation. So all this data is spread all over the country. And when I go to a new doctor, I have to summarize all that data. Every time. This cannot be the case. For every patient who has multiple diseases, this is a big problem. You take most of the time telling your story, and then there's a small time for interaction, for a good conversation. You do not want that. So you need to give patients access to their data and maybe be able to share that with their healthcare professionals. In this way, patients become a hub in their health data network. And these patients can also share this data with developers and private parties, which meet privacy demands, of course, for decision support, for AI, for instance. We've been working with Google DeepMind and Watson for decision support in a program together, seeing how these algorithms can help people get better health. So, as was stated in the introductions, I'm here to talk about personal health records. We changed that a little. We call it personal health environments, and I will say why in a minute. Our definition is this: a personal health record, health environment, I make the mistake myself now. Personal health environment is a lifelong tool to collect, manage, and share your data, and have your data in one place so a person is in control of his data. This is very important because people are not in control of their data. And the MedMy program is about creating trust and creating the preconditions about exchange. But MedMy program does not implement a personal health environment. If you vision a personal health environment as an open platform in which you can access all kinds of tools, this is done and provided by the market. This figure here on the right represents the personal health environment, where you connect, in this case, 8 sources, registries of information, to a platform which has services, and the patient can choose this service. Again, our governance for our program, because as stated, I'm part of a public-private program. In this program, we, the ministry, work together with the patient representation. Margot Brands is part of the Patient Federation in the Netherlands, but also knowledge institutes like lecture⠠ participate in the program. Our governance is made up as follows. On the top, we have our Information Council, which is comprised of these 16 stakeholders, umbrella organizations, and from those 16, 8 are part of a steering committee, which meets every month to decide strategic course options and products that are produced by the program. It's very important to have these people on board. To keep them involved means building trust. The day-to-day execution of the program is in the hands of the Patient Federation, the ministry, and lecture⠠. And what's interesting about this is that we made the Patient Federation the leader of the program. So as a ministry, we participate in it, and we set the right conditions concerning legislation and funding, because those are the instruments we can manage, but there are a lot of other things that must be addressed, and we're doing this together. And of course, we also involve lots of partners, expert groups, review boards, and on the field of technical, legal, and financial, and also IT developers. So we're constantly checking if the designs we are making in the program match the practice. So we're not designing and thinking some theoretical reality, but coming up with things, solutions for trust that are really implementable. So, our strategic goal, I gave you our definition on personal health environment. Our strategic goal is to have every person in the Netherlands in 2020 be able to choose a personal health environment. I see you looking for this slide. It's not in your handouts. There's some changes made later on, and this part is where it was done. We want these personal health environments filled with data. The personal health record part is about the data. A personal health environment is about health services. And we want people to have free choice of personalized digital tools. And what MedMy does in the program is to ensure the rules of privacy and security. So, I want to take you along with my trip. Our trip, we went in the Netherlands to come to the program. In 2014, the Patient Federation made a white paper on how to give people access to the data. Just after Parliament rejected our legislation, we were at a loss. We did not know where to go on this subject. And the Patient Federation said, well, you've been working on this system to connect healthcare professionals, but you forgot us. And they worked out what their vision is for the future for people. And they made a map of things that we needed to do. So they defined what a personal health environment is and what could it be for people. And they said, all right, if you want to achieve this and have people access personal health environment, you need to address a number of things. So they made a map of it to represent a journey you need to take. And this journey, you need to start to prove that you have added value for professionals and you have added value for patients. And this is represented in this part where the woods and the forests are representing the value. And when you can show your added value of a personal health environment, you need to address the exchange of data. This is represented by these aisles. What is very good about Netherlands is we've got all these electronic health record registries, but they do not talk to each other. So they're actually aisles without bridges. And you need to make agreements on how to connect them. Then, it's not technical only, it's also about funding. Because if you want personal health environments, apps, and all other solutions to be able to reach in a market, they have to have a business case, a sustainable business case. And this is what we tried to do, and we're trying to do in the program, and I will talk about that later. So, we prove added value, we implement business models, we create trust in the exchange, we identify health data, which data is supposed to be in a personal health environment to start with, and we define what it looks like. And in 2020, we have wide availability. The scope of the program is part of 6 projects, which is an answer to the travel. I will skip this, but I think the most important thing is the MedMy framework, which I will clarify now. Oh, I have a video first. This will help.
増え続ける健康関連のアプリやウェブサイトを使ってますます多くの人が自分の健康を積極的に管理することに関心を持つようになりました。称賛すべき発展ではあるのですが、私たちの健康情報がどれだけ多くの場所に保管されているかご存知ですか？ 病院、自治体、薬局、スポーツクラブ、いくらでも例を挙げることができます。この情報を一箇所にまとめることで管理、共有、活用が容易になります。また、あなたの健康の全体像を知ることができ、安心感や信頼感が得られるのです。メドマイではアプリや医療機関のシステムといった個人的な医療環境が安全にかつ同じ言語を用いてコミュニケーションが取れるようにします。メドマイはいくつかのルールを設定しています。医療環境と医療機関のシステムはメドマイが定めた要件を満たしている必要があります。それらの要件はメドマイの提携パートナーが異なる情報源から得られた医療情報を効率的に安全かつ機密として共有できるようにするためのものです。メドマイは健康状態の全体像を提供するだけでなく、あなたの健康をより緻密に管理します。詳細はメドマイ .nl をご覧ください。
So, let me clarify. To create trust, you need to have our answer to creating trust was to create a framework for trust, making a number of agreements, how you exchange data, which is very important. So we have got the systems of healthcare professionals, and we've got apps and websites that want to use data and generate data. And how do you exchange data? Our task is to promote the digital exchange of personal health data between patients and professionals in a safe, user-friendly, and sustainable way. This representation is very important in the program because all our designs and architecture and framework, a legal framework, is based on this exchange. Because as it goes now, there are a lot of proprietary couplings in the market. So there are hospitals that have a platform for the patients, and when the platform wants to access a new hospital, it has to make new arrangements about exchange. They all use different standards. This needs to be solved, because if you want to really reach a market, you have to scale up, and you must be able to trust on agreements on framework and on standards. So we want to create a network that can be accessed by any party that holds the MedMy certificate. So when you access this MedMy certificate, you can access data and send data to the network, and you're complying to rules for security and privacy. So this is the framework in a few points. The framework clarifies which parties must fulfill roles in the exchange of data, and it is clear on what happens when there's something wrong. So it says something about incentives and about sanctions and testing and objectives. Our framework has a clear governance, which is made up by patients and healthcare professionals, and it's all we're working on a maintenance and a security measurement. So this is our architecture. I will not clarify it, but to show that for the technical people that there are a lot of utilities within the exchange that must be implemented. This is about the fertile soil. So I already said there are a lot of data that could be exchanged with the patient. These are 5, 6 sets of data. But of course, in the Netherlands, we've got lots more data, and we make agreements on which standards are represented by this data. So you can also exchange information about your dentist or questionnaires or lab results for the future. So now, what is a personal health environment? Just to start with the style representation, this is Qli, one of our platforms in the Netherlands. A personal health record is just a start, representing a number of tiles of data. So this is public health, this is medical summary, this is measurements. So these data are added to the platform. But when you take it a step further, you've got all these services added to just a personal health record. So that's why a personal health environment as a health platform is much broader in scope. So you have a diary or a coach or communication with your professional. All these services could be added to the platform. And because we want an open platform, it is not the intention for one supplier to just make all the tiles. We want more cooperation and define APIs so this platform can add all these services. And we already got a number of developers that already offer these services in the Netherlands. So, for instance, Sodos is one of our kickstarts, which is a pilot in the Netherlands, but also Philips is on board. Philips is designing a health platform for the Netherlands, but also for the international market. And they're also having discussions and meetings in Tokyo for accessing and offering their services in the future. So, when you make health available, that's just the first step. You give people control over the data, which is a means to an end itself. But realizing health data is done by connecting to services. In the Netherlands, we had a Gupta strategist, which is a research institute, calculate what are the social benefits for society. And this amounted to 4.6 billion euros a year, based on 8 different services about self-measurement for chronic diseases, about information about medication, preventing these hospital admissions, but it's also about questionnaires, saving time, or about e-consultation, saving travel time for patients, for instance. So, looking here, to clarify the self-management, we made a calculation, and we said that we found that investing €1 in self-management would give the society a ratio of 4.4 euros, which was about better care, lower costs, and also the unemployment caused by disease went down. But when you look at the ratio, there's one party that has to invest, and there's another party that gets the benefits. This is where this was made very clear in the study, when we saw that the costs were made by the IT suppliers and the healthcare system, but the benefits were by the parties that execute the systems. So the government had lower costs on the budget, and the healthcare insurance. So we had a discussion with the doctors, and they said, you want us to invest in personal health environments, but this costs us a lot. In the first 2 years, 400 million, if we do it as a total sector. We don't have that money, and you're getting the benefits. So making this information, putting this information on the table and having a discussion about this solved our problem, in the sense that we knew the responsibility for investing in these new business models was with the state and with the health insurers. So it was apparent that we need to invest. And I will skip this one. I think I'm a little over time. Just to clarify, we made an agreement with the health insurers. So we want people to have access to health environments, apps and websites that give them health tools. We discussed it with the health insurers, and we decided that the ministry, the government, would pay as a launching customers for these solutions for the first 2 years. And the health insurers would pay for the infrastructure, for the access of the data. And by this partnership in private and public relation, we found that we solved the funding problem, actually the wrong pocket problem, it's called. And by the next year, we will have a subsidy which will give money to personal health environment developers and it's based on the number of active users. So for instance, if you we give €5 for every user of a platform, which adds a lot of extra funding to the market, which enables it to grow and meet the new demands, the new standard on security and privacy, which is based on the MedMy framework. And then eventually we want the platforms and the solutions to grow. So this is represented in this figure. So my last slide for today. This is Mike. Mike is from Malta, and I met him last year at the eHealth Week in Malta. Mike is over his 70s, and he's a very active, strong person. He's a very sharp mind. He's one of those super people, super elderly. And Mike lives in Canada. He's a widow, but he has children and grandchildren, but they don't live near him. And Mike, he's a very special person because he's very close to himself, but he has no technology. He has a toaster, but he has no mobile phone, he has no computer. And once every year he goes to Malta, so he travels to an agency the old-fashioned way. He does not have booking.com, and he books his tickets. So everything Mike does is like the way it was 10, 20 years ago. And Mike has concerns about eHealth because I was just on the eHealth Week conference. I was really enthusiastic about everything I saw, and I tried to explain the opportunities. But Mike, he had questions about security or privacy, about the human side of healthcare. And having this discussion with Mike made me clear that we need to keep talking to patients and to people about this change in society, because when the change was in travel or in financing, it was easy because everybody found out it saved them time and saved them money. But then you look at healthcare, you get scared because you might have a little time with your doctor, or maybe he says, well, here's a program, help yourself. So please, my point for today is, if you implement healthcare, if you make policy for exchange, it's about economic benefits, yes. It's about big projects and big programs, yes. But keep listening to the people and ask what they want and what they think about it. So this is my last part of the presentation. Thank you very much. I think I have 7 more minutes for questions. Any questions?
ただいまもお話ございましたように、ご質問の時間少し設けられそうです。質問のある方はお手を挙げてお知らせいただけますでしょうか。お願いいたします。今マイクが参ります。
Thank you for the very nice presentation. I was very impressed. But on the page of the page 22, on the page 22, I would like to know what kind of private companies are eligible to join the program.
Yeah. Can I have
maybe in the world, lots of IT companies or the healthcare providers, insurers are providing their own programs.
Yeah.
Page 22.
Oh yeah.
Page 22. And in Europe, even in Europe, you have lots of companies. In Germany, Estonia, Finland, Holland,
Yeah.
So I really would like to know. Page 22? Oh.
I'm looking for it,
No?
but it's
I'm
not
sorry.
on the
Yeah.
right.
Okay. No, before that.
Before this?
Yeah. Oh, yes, this one. That's page, this one.
Yeah.
You pointed the steering committee and the execution programs. Maybe the companies like in the steering committee,
Yeah.
What kind of companies are eligible to join that
All
committee?
right.
Yeah.
Yeah.
Thank you.
what is important for us is that the program is initiated from the part of the demand. So this is about healthcare providers and patients implementing new solutions in their process. So we made a deliberate choice to have those people in the steering committee and not involve big IT companies. So it would be an option to ask Philips, for instance, to join and reflect on what we're doing, but that would create a lot of interference and also interests that were, I think, they are great because Philips, they're seeing this as a market, so they want to invest for the future, and just asking Philips would give a huge advantage concerning their other competitors. So there was a slide about a number of suppliers, their logos. So they're all equally involved, but we have focus groups where they are involved. So we have a public consultation about the framework. So we publish it, and then we ask all of the parties, including Philips, to say what they think about it and if they can manage this. So this is why on the right we continually check with the market, but we're not choosing for any solution or any supplier because, of course, the authority will also not like that. So that's those. I think as a ministry, you have to take into account that you do not give anyone an advantage.
Yeah, thank you. Because it's a very important point.
Yeah,
thanks a lot.
Yeah. Please. Any other questions?
もうお一方お時間もあ
We
りま
can
すので、
take
よろしけれ
another
ばお手を挙げ
question.
てお知らせ
Please
くだ
raise
さ
your
い。
hand if you have any.
Kazuko.
大変貴重なご講演
Thank
あ
you
りがと
very
うご
much
ざいま
for
した。
the
特に
lecture,
病院の関係者
especially
ですとか、
about
そういった
the
ところでこういった
hospital
ICT を入れることに
related
対して、
people. If you
抵抗
include
感というか、あまりやり
ICT,
たくないな
were
っていう
there
よう
any
な気持ち
resistance?
も出てくるところもあ
There
るかと
may
思う
be
んです
people
が、
who
オランダで
wouldn't
はその
want
あたり
to
をどのように説
adopt
得していったのかと
ICT.
いう部分を教え
And
て
the
いただけます
Netherlands,
でしょ
how
うか。
did you convince the hospital members or staff to involve ICT?
Yeah. The answer is simple. 105 million euros. What we did is, when you think of the slide with the fertile soil and the good climate, we found out that a part of the infrastructure was about the digitalization of healthcare, of hospitals. So these hospitals, they have their own systems, but they were very old. So we said, we understand you're having trouble, you want to go with us, and your personnel has to go with us. So we made a subsidy for all hospitals. In the Netherlands, we have 70 general hospitals and 10 academic hospitals. And they all have their different systems. And what we said is we give you a subsidy for two parts. One part is for organization, so education of your patients, education of your professionals to implement a new ICT. So they're changing their electronic health records systems at the moment, upgrading the IT level and making the connections to the personal health environments. So 50 million roughly is for the person, for the people in the organization, and 50 million is for the technique. So the hospitals get the money and they invest it with their vendors for the next stage of IT. And what we see is that they're making strategic choices because we want a personal health environment which is an open platform, and they are building mainly portals. So they've got digital service for their own hospital, and what the risk is that hospitals use the money to close their systems even more. So this is the discussion we have. So if you invest in a sector for hospitals, you need to make clear that you do not want only digital service in portals for patients, because those are really just one solution at one supplier of one healthcare professional, but you need to connect all those hospitals with the patient. But the 100 million was a very good incentive.
ありがとうございます。
それではお時間となります。
Thank you very much. Time is up. Thank you very much for the discussion. And Mr. Eisinger, thank you very much for the speech.